That is a very good question, but I think we need to slightly reframe it, because if we are talking about preventing psychosis from ever happening, then the honest answer is no, not yet. But if we talk about improving our patients' quality of life and functioning, then the answer is clearly yes. Now we can improve most of the more severe and disabling outcomes traditionally associated with psychosis. Over the last decades, we have learned to put quality of life and functioning at the center of care. Psychosis is not a single entity, not a static one, because it changes over time. And it's because of that that we now provide specific states and personalized interventions, ranging from clinical high-risk states to first episode psychosis and more complex chronic forms of the disorder. We also know that psychosis is a complex interaction between genetic or neurodevelopmental vulnerability and environmental factors. So we offer state-specific interventions and evidence-based interventions. When we talk about prevention, we need to distinguish between three levels. Primary level aims to decrease the incidence of any illness, in this case psychosis, before any symptoms start. Then we have secondary prevention for people with subtle or early stages of the disorder, with the goal of slowing or stopping the progression to full psychosis. And then we have tertiary prevention, which seeks to limit the deterioration or disability associated with psychosis after onset. Now, the most strongest and convincing evidence lies in secondary and tertiary prevention. In clinical high-risk people and in those with very early stages of psychosis, structured psychological and psychopharmacological interventions can decrease symptom severity, improve long-term outcomes, and in some cases even lower transition to psychosis rates compared to usual interventions or usual care. CBT, cognitive behavioral therapy, family interventions, and support targeting stress, anxiety, and depression can make a real difference in the final prognosis of these individuals. At parallel, early intervention services that provide rapid and comprehensive treatment after a first episode psychosis can also improve these long-term outcomes. But talking about prevention, we need also addressing modifiable risk factors. Continued cannabis use, especially hypotensive cannabis use, can increase relapses and poor outcomes, while cessation substantially can decrease this risk. Other social or environmental factors, for example, trauma, social isolation, discrimination, stigma, or barriers to access, can also play a major role in the prognosis. Interventions that provide trauma-informed support, strengthen social networks, decrease discrimination and stigma, and limit barriers to access or improve these barriers to access can also make a difference in the final prognosis at both individual and populational levels as well. But obviously there are several limitations as well, because with the current knowledge we cannot make a prediction of psychosis at individual level, because many of these individuals with clinical high risk for psychosis never develop psychosis. And obviously there are several ethical limitations associated with early intervention and labeling. But anyway, in summary, while we cannot prevent psychosis itself yet, we can improve long-term outcomes, delay onset, decrease risk through early, comprehensive, and personalized interventions. So prevention must be cautious, proportionate, and person-centered.